It's great to see everybody. Great to see many familiar faces and names, folks that we only see sometimes by name on the listserv. Particularly appreciative of those of you like Diana, um, Deborah. I looked at the wrong name here. Deborah from the AIMS Center, who's going to bring some expertise here with us, and others who just have really good knowledge of collaborative care model implementation approaches. So we have intermixed in the group intentionally folks who are a little bit further ahead, and I just want to recognize that we're also going to have folks who are not so far ahead who might be at the very conceptual stages. Structurally, what we're going to do today is pretty much an open forum. What I'm going to have is I'm going to make some opening comments based on a listserv conversation, and also we had a similar community meeting about a year, maybe year and a half ago, pretty close to when these codes were a lot newer. And so I'll bring some comments related to that as well. But I want all the speakers, everybody who participates, just to acknowledge that there are people along a continuum, some folks who are just now thinking about how they might implement the use of these codes, and some folks who have already experience with having successfully, or at least partially, implemented the use of these codes as well. I also want to make it fair game for all of us that if there are particular implementation questions that go beyond the codes, because this CoCM implementation is not just about billing codes, it's really about establishing pathways that really work for your particular clinic setting. And so there may be questions related to that people may want to ask as well. So if you look in the chat box, by now hopefully you know how to find the chat. At the bottom middle of your screen, you can open up the chat. I've put in some of the questions that I get asked a lot, and that I also inferred from the listserv conversation. So the basic question that I think initiated things for us was, how are these codes being utilized? How are they being actualized is probably a better way of putting it. How are documentation requirements being managed? That's a key question I get a lot with regard to it, because you want to be able to obviously be charting time, noting the right kinds of activities in your documentation to support the billing process. And that's a little bit different than just an episodic fee-for-service type documentation. And then another big question, obviously, is the copays and deductible situation for those patients who do have those. And then how is the service being offered and marketed is another key question, especially because most clinics have diverse payer groups that are paying for care on behalf of the patients. How you market the program and how you help educate your providers to talk to your patients about this becomes a key issue. Based on their payer source and whether they will pay or whether the patient will be paying, whether there'll be copays, deductibles, et cetera. And then just generically, what are the key implementation components? So sort of what makes it successful? What helps make this work in some settings more successfully? Now, there may be more questions, and I encourage you in the chat box as we're discussing to pose those particular questions that you may have and want to have answered today. But I also want to encourage folks to unmute as they're able to, show your cameras as you're able to. A good view for this presentation, given that if we need to share screen, I will share screen, but the intention here is not to share screen, but to rather see faces, to talk, to troubleshoot, and really get some real actionable, hopefully, action steps that people can take home and say, okay, I can take this next step on my pathway towards implementing the CoCM model. And thank you, George, for letting me know that some folks don't have access to the key questions. I will copy those in again here for everyone who can't see them in the chat box. There they are again. Thanks, George. All right. So I'm going to first just start off the conversation by asking a question from the group. And I want to just ask just generically, as those of you who have specific questions, post your questions on the chat. I'll facilitate that portion. But I would like to ask those of you who are further along or who, like Deborah, for example, are helping people who are much further along, what you have seen to be the steps that have been most helpful, sort of if you could nail down step one, step two, that have been most helpful in making this happen, in successfully not just implementing the model, but also successfully billing for the model. What are the things that you have found to be most helpful that clinics have done on their journey towards making this happen? So I'll open it up that way. And Deborah, if you don't mind me picking on you, would you mind kicking us off?
I don't mind. Thanks a lot. And my colleague Diane Powers is here for the first half of the meeting too, so
Awesome.
she can certainly add on. But I just took a caveat. We don't actually do any billing of collaborative care at the AIMS Center. What we do is work with a lot of practices that are doing it or are trying to do it. And mostly we work with practices that are doing the collaborative care model, and they have an option of how to bill. But for billing the collaborative care codes, I think the most important thing is for the practice to really think about how they want to bill, look at their options for billing either through psychotherapy codes or collaborative care, and then really talk about what the workflow looks like for doing that and get into the details about where are we documenting our work? Do we have does our EMR help us be able to record minutes in an efficient manner? Do we need to use a registry to help do that? And what does the actual billing workflow look like for doing this kind of monthly billing? Because that is a big change for most practices, to sort of pull together minutes at the end of the month and bill them out. So I think just doing a really careful deep dive into the details is before starting is really a helpful thing to do. So Diane, do you have anything to add about that?
I think the only thing that I would add is just that you can use the psychotherapy codes, you can use the collaborative care codes, you can also use a combination of the two. So they're not, yes. You don't have to pick between the two. It is possible to do both, and a lot of practices find that to be the most advantageous way to go. And so I think what Deborah was saying around, in the same way that you want to develop a really clear clinical workflow, you want to have a really clear billing workflow and engage the folks from your billing and coding department in developing that with you, so that the clinical and billing workflows really talk nicely to each other, and each of the groups knows, which piece is theirs, because you need those two to really talk to each other efficiently and effectively.
Great. And Phillip, I'm going to come to you next here for your comments. But before that, I just want to kind of do a follow-up question on this, because this is something I've observed as well. So I totally agree with that assessment. I think getting your workflows down in detail really demystifies the process. I think because it's so different than fee-for-service billing, it just feels a little bit more onerous than sometimes it is. Have you seen that clinics that have sort of a more like a dedicated care management service do better at this than having a clinician sort of part-timing the care management component, or do you feel like that doesn't matter? And I guess the backdrop to that is I have just not, this is not a scientific survey, this is just observation. But sometimes I've found that if a clinic does sort of segment the care management component, they're sort of able to troubleshoot that piece, versus if they're like allocating 0.25 FTE of a behavioral health personnel to try to implement this, it gets a little bit funky because it's so different and they're trying to manage two different kind of flows.
Yeah, I think we've certainly found at Ames, just for implementing the collaborative care model and being able to really do all the necessary components of it, it's really helpful to have someone at least half-time, but ideally a full-time care manager, that's just what they do. And that's, that's how they do the work. And then the billing is just another part of that. I don't think it's necessarily, super critical to have a full-time person in order to be able to build the collaborative care codes. But to be able to do the model with fidelity is, I think it takes some real focus.
Yeah.
And the only thing that I'll add to that is really around the fact that that set of responsibilities that need to be accomplished by the care manager don't have to be accomplished by one single person. So it's a set of actions. And we've worked with lots of clinics that have the two people who share responsibility for those actions. So for example, you can have someone who's a licensed provider who's doing the activities on that set of responsibilities that require a license, and they may be paired with someone who is a medical assistant or a community health worker or a navigator or someone like that, who are doing the set of responsibilities that don't require a license. And, that requires some close communication and coordination between the two of them. But, that can be a way that can help mitigate, if you have someone who's not, who's not full-time, who's the licensed provider, so that you're really using those folks for the things that require a license and not for things that don't.
Absolutely.
Can I just add one more thing to that? There is a caveat with that, in that when you're billing with the collaborative care codes, you're only billing for the time of the behavioral health care manager. And all the payers have some requirements for what are what's the licensure or educational training requirements for the behavioral health care manager. So if you are splitting the role, you need to just be aware that some of the minutes of someone who doesn't qualify to be a behavioral health care, the minutes of someone who doesn't qualify are not going to be billable. So that is, for the model itself, it's fabulous to have, to be able to split these responsibilities sometimes. But for the billing, it's a little bit trickier to decide whether or not we can bill for this particular sort of activity. Yeah. And it's performed by this person.
Yep.
So,
yep. Absolutely.
If I could just make a comment on this
Phillip,
topic.
Oh, sorry. Go ahead.
Is you mind? So this is Amy Jones. I'm the Director of Primary Care and Behavioral Health Integration for the New York State Office of Mental Health. Work closely with Diane and Deb. Hi. We've been doing collaborative care statewide in New York State since 2015, and I currently support over 300 primary care practices. So what I was going to say earlier, it just kind of dovetails on that, is that I think the concept of buy-in is really what we have seen be most important, which kind of sounds like a duh statement probably, but having actual buy-in from the primary care staff and providers has been so important to even in the billing, to kind of get them to know like what the model is, why this is different from other approaches to integration and care, what the real role of this behavioral health care manager is, to make sure that that care manager is, getting handoffs, getting appropriate warm handoffs, able to really build their caseload. And so when you have a behavioral health care manager, not so much if you have somebody that's only there part-time, although we do recommend at least the 50% to have a significant presence. But if you have somebody that's kind of wearing multiple hats, so they're there more, but they're only devoting some of their time to collaborative care, we find that becomes really tricky. And although it can be done, I think it's hard to kind of solidify the collaborative care workflow if they are dealing with patients in like multiple modalities, to really be able to build a significant enough caseload to make this financially sustainable. So often, for example, they kind of slide into maybe old practice patterns of just doing traditional psychotherapy, so to speak, seeing more patients just in person for traditional visits. So they have the ability to take on less patients. Their schedule isn't as flexible to take a warm handoff, that sort of thing. And they end up having less patients that they're actually able to meet the billing requirements for collaborative care. And then that kind of trickles down into financial sustainability problems as far as who they can bill for. So that sometimes becomes tricky when the same person is doing multiple roles. We have had it successful. It just takes a little extra forethought and like a lot of strong buy-in from the other members of the clinical team. And we do have people that, are doing this role basically 100% virtually even prior to COVID. So, it can certainly be done with varying degrees of physical presence in the practice. But, I would caution against what other tasks that person may be taking on in addition to collaborative care. Thanks.
Thanks, Amy. Really appreciate that. And I just want to reinforce that whole, buy-in sounds a little bit like a soft term, but another way to think about buy-in operationally is just education. Like your providers need to know what the goals of your service are, what types of patients are appropriate for that service, how to access the people that are going to be part of their team as part of the collaborative care support. So that's all part of buy-in. So it means you have to do that upfront work to prep your teams for their new team members. We skip ahead too fast sometimes to the operational implementation, and we skip actually letting our teams know, hey, you've got some new team members, and this is what they do, and this is how they can be helpful. And what do you think about that? That to me is sort of an operational way of thinking about buy-in. All right, so I want to get to a couple of people, but I also want to just alert you if you haven't seen the chat that's going on. And if I do note there's some questions there. We're going to get to those questions for sure here in a moment. If you want to keep adding and participating on the chat, it's going on while we're talking. So Phillip, can you give us just a couple of your thoughts around sort of key pieces, what you would counsel folks as they start implementing, not just operationally, but from billing sustainability standpoint?
Yeah, so my name is Phillip Hawley. I am the Primary Care Behavioral Health Director at the Yakima Valley Farm Workers Clinic. So we're in Washington and Oregon State. And we did a presentation, I think this was at Houston CFHA. So what's that, been about 3 years ago now? Mm-hmm. And we did a collaborative project with the AIM Center and running primary care behavioral health as well as collaborative care for a 1-year project at that time. And I think this kind of echoes back to what people said initially in really trying to figure out what resources and what problem your clinic's really trying to solve. I think that was one of the things where I think people sometimes get kind of a mismatch when you're focusing more exclusively on the financial piece versus what kind of resources and what providers want. I think that idea of buy-in is really important. And if you're kind of trying to force something that isn't what providers feel is the most valuable, that buy-in can be a little bit tricky. And so I think that's just the thing that I would really encourage people is really sitting down at the beginning and trying to figure out, what are we trying to do here? What is our patient population? What are our providers identifying as their highest need for behavioral health? And really trying to kind of align that with something that makes sense. We also found that within this, you can really be, I would say, creative, probably the best way to do that. And even we worked directly with a payer. So looking at that payer diversity and even having some specific talks where we didn't use the collaborative care codes, but we set up a collaborative care kind of contract with one of our Medicaid payers and really set up that system with them in a way that allowed us some flexibility and allowed us to then kind of meet some of that financial sustainability as well.
Thanks, Philip. And that certainly works. You're probably talking about Medicaid in your state. So with a big payer like that, that definitely makes a lot of sense to have those conversations with payers as you go. And this does involve some conversations with payers often because not all payers recognize the codes. So, but it's worth having conversations because a lot of times the payers, it's not that they're not paying for the codes intentionally, it's that they're literally like, it's just not on their radar as a kind of a key issue. So if you have some conversations with folks that you know in there and say, hey, you know, such and such is paying for these codes, your competitors here are paying for these codes. I think that's part of the on the ground advocacy that we can do to help move this along. So definitely have those conversations. I want to ask two more people to comment, and then we're just going to free for all here. Lori Rainey, and then Erik Osland, if I can tap him for a few comments as well. So Lori, you may have jumped on a little bit late. We're just doing some introductory comments on the one or two things that you've found. And in your, Lori has a very helpful role here, having helped many clinics in actual implementation of CoCM. What are the one or two things that you think have been absolutely essential for successful, not just implementation clinically and operationally, but from a billing standpoint?
Hey, good morning, and Natalie, thank you. I was trying to get my video up, but I'm on vacation and I'm in a travel trailer, and it just isn't quite working this morning, so I apologize for that. I'm going to go back to my lovely picture. But Natalie and the team, I would say the number one thing that we have found across the country is going even a layer deeper on buy-in to PCP buy-in. And you guys know that from a lot of integration projects that you've done, that not all primary care providers will welcome in any kind of integration program. As you were saying, you've got to educate. This is even another layer of PCP buy-in, because what we're trying to do with the collaborative care model is to get the PCPs comfortable prescribing and treating patients with mild to moderate behavioral health conditions and not referring them to specialty behavioral health. And that is a big step for them, especially if there may be medications prescribed. Remember, this is not a medication model. Medication is an option. I actually have collaborative care programs going where hardly any patients are on medication, especially when you do it in OB. But to make that shift, for the PCPs to make that shift to that they're going to be the ones doing that, can be quite tricky. It's that old adage, everyone wants integrated care until they learn they have to change their practice, right? And so for me, the hardest part is, or the place to start, is to really start in med staff meetings with those primary care doctors, making sure they're understanding what the model is and how it's going to help them and how it's going to help patients and how it's going to stop the pipeline of patients headed to specialty behavioral health, especially in the middle of COVID. You know, we're not going to be able to handle all those patients that want or need to go to specialty mental health. How do we back that up and take care of them in primary care? So PCP buy-in has been, for what I've seen across the nation, one of the biggest stumbling blocks. The rest of the stuff, developing a registry, you know, getting the notes in the EHR, finding and training a care manager, those are all doable things. But if a PCP doesn't refer a patient for collaborative care, your collaborative care program's dead. It's dead in the water. So that you have to, to me, it's a real starting place. And getting your psychiatric consultant, yourselves, a PCP who understands collaborative care. We look for a champion. We don't even start a collaborative care clinic without a collaborative care PCP champion, because that person, you know, as you guys know, infects the rest of their colleagues with enthusiasm around any form of integration, but in particular, this form of integration. So as I look at the clinics, I interview, I watch, I see which PCP has their arms crossed, which one's listening, which one's leaning forward, which one looks excited, and try to then really develop that collaborative care PCP champion to help spread the love. That to me, you trying to fill your registry and you don't get any referrals from primary care for collaborative care, your program, you know, you're not going to be able to fund your program. So that's, for me, that's the biggest point that we have struggled with nationally. You got to start there. You can't skip over those guys and assume they want it.
Yeah, and I think that's a great point, Lori, and that's where I often take my billing conversations, because, you know, there are solutions to the billing, to the documentation, to the workflows. There are solutions in nearly every setting. There's some solution to these problems. It's funny how practices will focus on those and forget exactly what you're talking about. And really what we're doing is we're aligning with all of the work on change management on teams, right? So we're the same exact conversation is the same exact conversation you're going to have if you're implementing PCMH, or if you're implementing PCBH or collaborative care model. Without a clear a change pathway on your team, which is what we term buy-in, we just don't get anywhere. And then we kind of blame it on procedural steps when that's not really what's happening. So one last one before we open up. Erik Osland is a good friend of CFHA and has great experience in the state of Arizona making integrated care happen across a diverse array of clinics. So Erik, you've got a lot of actual implementation experience. It's a little bit unique in the way you're going about it. But as you've done that and as you've landed people into these clinics and tried to develop these pathways at very, very different organizations, how have you made that work? How have you been able to make that a repeatable process?
Yeah, I feel like we're in the weeds of it right now. We've got 6 new clinicians starting next week. That'll be spread between Phoenix and Tucson. But I think at a very high level, I agree with everything that Lori said about understanding the environment and helping the providers understand what you bring to the table. And so there's a wide array of folks on this call who may be focused on, call it a system level sell, an independent practice level sale. And so what I would encourage everyone to do really is, first of all, we have a group of clinicians that are passionate about helping people. For a moment, take off your clinical hat and put on your sales and marketing hat, because the success of this program really relies on our ability to articulate what this program can do and how it relates to the individual incentives of the players involved, right? So if you're selling to a health system, there are certain incentives that are involved at the health system level. And then as you trickle down to the individual providers, they each have different incentives. And so as you're going out and talking about the program from a clinical perspective, think about how this will drive an impact to the individual stakeholders and their incentives. So if you think about an individual primary care provider, incentives might include, you know, better patient care, and not just better patient care from a mental health perspective, but better patient care from a physical health perspective, right? So you've got this patient who's a diabetic, who this provider has seen for the last 10 years, and they have not moved the needle clinically. Well, how can we drive a better clinical output for that patient by relaying mental health or behavioral health services? The incentives might be better efficiency when managing patients, right? Because everybody knows, every physical health provider knows the patients that have an underlying mental health condition. Those are the patients that turn a 12-minute patient block into a 45-minute block. So how can we articulate the value of integrated care to help that physical health provider focus on physical health and defer the behavioral health components to the on-site behavioral health manager? It might be about compliance or risk. You know, we have a lot of providers right now that are managing chronic pain patients on opioids. And in the state of Arizona, at least, there are specific compliance guidelines and a lot of risk around that category. And then finally, the economics of this program. If you have an independent practice, the economics and the financial viability of collaborative care are much, much more important because they aren't sitting on a huge cash position. But if it's a health system, it might be around value-based payments. It might be around population health. So, you know, really understand the incentives on the front side, make sure you're educating the individual stakeholders to their individual incentives. And then don't just stop there, right? It's about rolling the program out, helping them understand how they can drive value for themselves, and then continue to manage it, continue to monitor activities at the individual stakeholder level, and then hold them accountable, right? So this is kind of sales 101, right? If I'm in front of a provider, they're more likely to buy. And we do a really good job of that on the front end. We get them bought into the program. It's a nice, shiny object. And then guess what happens 60, 90, 120 days later? They start to forget about it. So we have to be constantly in front of them, helping them understand how they can continue to leverage the program. We have to monitor their activity as it relates to referrals into the program. And we have to hold them accountable. You know, you're going to have a 10-physician group where 8 physicians are referring into the program actively, and then there are 2 that don't refer at all. And so it's about going back to those providers, having a conversation, understanding what the stopgaps are for them, and then helping them overcome that. So that's my general thoughts about how to get the program out there, educate, and then continue to monitor.
Excellent. And just so you know, Erik and his team at Evolved MD have been doing this in a fee-for-service environment. So that should be an encouragement to all of us who are, most of us are in grant-based programs or FQHCs and things like that. So the fact that they've been able to do that successfully is fantastic. All right, so great general conversation. I want to dig deep into some of the specific questions, and we'll start here with one of the issues. Matthew Duncan posted a question in the chat that is one of the operational issues that clinics do struggle with. His comment is around consent. So I'd love to hear how practices are handling the PCP consent of patients, including documentation standard of consent. I'm assuming here this is related to consent for registering for the program, essentially. So that's been a key issue here because it requires an additional conversation, and it dovetails with that conversation around the potential for additional copays or costs to the program based on the payer source. So what have you guys been doing, or if you're even in the implementation stage, what have you been thinking related to how you register patients into the program and how you do both the education and then just procedurally, how you handle that actual documentation of the registry of the individual. And feel free to either put in the chat or just unmute yourself.
I'll go. This is Monica. Can you hear me?
Yes, yes. And thank you,
Hi,
Monica,
everybody.
for your awesome chat responses. Thank you.
You know I talk a lot, Tyler. Okay, so I've seen it done different ways. I will say in the current situation that I'm in, their initial thought was that the primary care provider would do it. And what I will say is, and not only in the clinic I'm working with now, but others, that is a difficult challenge to ask the primary care providers to spend, not saying they couldn't do it, but it's a difficult challenge to ask them to spend the time with the patient explaining all the ins and outs of the program. So currently what we're doing is the primary care provider is saying that there is a program. We have pamphlets that they can provide to the patients about the program, but ultimately when I call them, I am the one, or if I go into the exam room after they've talked about it, I am the one that's getting into how the copays work, like the nitty-gritty of the program. That ends up being me. And so then there's documentation set up in our Epic system to make sure we're capturing that with the wording that's been provided by CMS.
That's a pretty typical workflow that I've heard as well. Any other workflows that people are doing? I don't know of any programs that are leaning heavily on PCPs to do a lot of the lifting here, because I think universally that's not a good way to go. But any other thoughts about that? Yeah, go ahead.
This is Deborah from the AIMS Center. We do train to the ideal standard of primary care provider talking to the patient about, I have the team to help me with problems like this. It has a psychiatric consultant and a behavioral health care manager. There may be additional expense to participating in the program? And are you interested? Would you like to, take the next step to meet with the behavioral health care manager? It can be very simple, and that there is a standardized smart phrase in the EMR that the PCP uses. That is the requirement for regular practices billing Medicare, is that the PCP actually has to be the one to get the consent. FQHCs and RHCs can involve other team members, and in terms of private insurances or state Medicaid programs, I haven't really seen any specific requirements around the consent, or even that there is one. State Medicaid program, there isn't going to be no cost sharing, so that part isn't so critical. I would argue that anytime a primary care provider makes a referral to another specialty services or to internal helper services, there should be at least a nominal discussion of the fact that there may be other charges, because there is. This is no different than any of the other kinds of services that a PCP may encourage a patient to get. And then I would absolutely say the care manager, or whoever connects next with the patient, is the person who really gets into the nitty-gritty of what is this going to look like, and maybe gets help from the billing folks to say, what is the copay going to look like, encourage people to call their insurance, all that sort of stuff.
And just operationally, I think, Jen, I'll come next to you. Operationally, I've also seen a lot of times where the care manager is also actively looking at patient panels and cueing the provider related to the suitability of a particular patient for the approach that the provider has that initial conversation with the patient, or at least provide some indication to the care manager, yeah, I think that patient might be interested in hearing more about that, about the program, and then the care manager can make that follow-up phone call around that. So, yeah, Jen.
Yeah, hi, I'm Jen Thomas. I'm a PCP and a director of integrated care at Morris Hospital. So we're a small, independent, rural community hospital in Northern Illinois, about an hour and a half from Chicago. And we've had the fortunate relationship to get a lot of coaching with AIM Center. So I would say for the PCPs, we sort of do it by the book with the smart phrase, but buy-in from my colleagues, we had to make it simple and easy. So it was just click this template, coach them up on, go through the team-based care. This isn't free, there could be additional charges, but that was a big selling point, was for the PCPs to actually do it, because we found they weren't initially, was we had to make it easy because they have a lot going on. So it's worked out well once we've had the smart phrase built into the EMR.
Yeah, easy buttons help. Yeah.
This is Shanda at the University of Wisconsin. We've been doing collaborative care for about 4 years now. And in our practice, we have the BHC's consent. So the PCPs do the general intro. This is a team member, kind of like Deborah was saying. But the details about what might be billed or not billed is, we have a script for the BHCs, and the BHCs introduce it. And they highly encourage all of the patients to call their insurance.
Yeah, that's a really good little tidbit there. Just because the last thing you want are patients that are really surprised at what their insurance actually ends up doing with the charge that you send through. Yeah.
Yeah, we have and I will say there's pluses and minuses to this. I'll be the first one to admit it. We as BHCs probably know a little bit more about the insurances that are, like how they'll react and what we get paid for and what we don't get paid for and what patients will receive for bills. But we don't know absolutely, so we always have to add the caveat of, but make sure you check with your insurance, because we don't know what your specific plan does. And I will say that inevitably there's always like occasionally someone who gets a surprise bill and we get surprised by, or something like that. And having the provider be the one have that conversation with them is not always like therapeutically conducive.
Right. I want to kind of put the wrinkle on that I often hear with this consent conversation, which is patients who don't have insurance. So just like to hear how folks are handling that operationally. How are you handling folks who don't, and doing so without creating haves and have-nots in your patient panel?
Neftali, I'll start real quick on this topic. I think it depends upon the payer landscape in your individual state. So in Arizona, we have a very strong payer landscape. We are seeing adjudication on claims to the tune of 85 or 90%. So when our adjudication is that high, we have a lot more flexibility in providing charity care. And so our approach in our clinics is that if a patient has a need, we provide the service regardless of payment from the payer. And granted, we have that flexibility because we have such a strong payer and on the back end. Beyond that, you do run into some cash pay patients. And for those, we will typically mirror the office visit physician for cash for that office, right? So we are simply mirroring the primary care practices policy for those types of patients. So, you know, but beyond that, I think there's a way to mark the pricing down if you don't have a strong payer landscape in your state to make sure it's affordable to all patients. And certainly it's something that we focused on.
This is Aubrey, and we haven't figured out how to bill for collaborative care yet. We just started our pilot in May. But I wondered if anyone else has run into a challenge. This is, I guess, fleshing out the question about billing. Our institution, and I don't know if this is our institution only or if this is pretty much universal, doesn't allow us to do any sort of selective billing. So we can't not bill people. If we are, it's a binary. We either turn on billing, we bill everybody, or we turn it off and we bill no one. And I'm getting some head nods. So just running into some challenges there with not wanting people to be saddled with exorbitant fees, but wanting to capture those who do have insurance and not being able to really strike that balance ethically in terms of the billing, the financial landscape. So had been advised at one point to maybe think about collaborative care codes for people who have those codes turned on, and then psychotherapy codes for those who do not. And just curious if anyone had experimented with that.
Aubrey, it's Lori Rainey, absolutely. And so you're still offering someone care. It's not like you're not offering them care. And this happens with Medicare patients and others for all kinds of other treatments that might be available if you have this insurance, but it's not paid if you have that insurance. So you're able to offer them you know, the psychotherapy or some sort of behavioral health treatment, and then you can have a different kind of behavioral health treatment if they have insurance that covers it. So absolutely, that's the workaround. Usual care. I'm sorry, go ahead.
My question back to anyone else as well would be if there's been an issue with the number of copays that a person would get when you're billing psychotherapy codes versus collaborative care, and whether or not that's equitable.
Can I add to this conversation? This is Deborah. I think regardless of whether you're billing psychotherapy codes or collaborative care codes, if you're billing anybody, you have to bill everybody. That's a rule covers everything. FQHCs and RHCs have other mechanisms on the back end for saying we're going to bill you, but you're going to have all sorts of flexible payment plans or sliding fee scales or things like that. But it's not an issue of which billing style you're using. The same rule applies. So I don't think billing somebody with psychotherapy codes is going to help them if they are uninsured and don't have money to pay.
It's that some insurance, if they are insured, some insurance companies have turned on the collaborative care codes and others have not.
Got it. Okay, I misunderstood. So
yeah,
yes,
I kind of asked two different questions at once. Sorry about that.
It's very common that you might bill collaborative care codes to some insurances that pay for them and bill it through psychotherapy codes, even though you're providing, potentially you're providing exactly the same service to everyone. You bill it differently depending on what the patient's payer is. And whether, like in Washington, our state Medicaid pays for collaborative care codes, but in most states, that's not the case. So you're not going to be able to bill collaborative care to Medicaid. You have to bill psychotherapy codes, even though you may be having the psychiatric consultant and doing exactly the same model with everybody. So that's how we approach it at AIMS.
Similar to Deborah and Lori, we do have to bill everyone for the reasons that Deborah mentioned. But in our state, Medicaid has not turned on the collaborative care codes yet. We were set to plow that thing down this year, and COVID happened. Kind of everything else went on a standstill. But I still do get referrals from primary care providers for Medicaid patients. And that is a part of the discussion I have when I'm doing the consent. And sometimes patients do decline. We're a larger system, so we also have PCBH clinicians and traditional outpatient therapists as well. So I end up connecting those patients because I'm not doing PCBH and CoCM, I'm strictly doing CoCM. So I'm able to connect those patients to other services if they decline the collaborative care portion. So I have had to do that. So the patients get something, and I'm doing this extra work without being able to bill for it, but it's for the better quality care of the patient. And so our system recognizes that and has been fine with us kind of working with each patient as they approach with what they have going on.
Go ahead, Shanda.
Aubrey, I will just say, I don't know where you're at, but I'm not at an FQHC. I'm at an academic medical. Okay, I'm at an academic medical center. And so what we've ended up doing is currently we're doing collaborative care and we bill CPT codes, and people have copays associated with that. It differs depending on plans and coverage. And then we're trying to implement the collaborative codes on top of those. So we would be billing insurances for the same patient, both of those codes, depending on what activities we're doing. So like for actual face-to-face now therapy, we'd be billing the CPT codes, but then looking at adding on the collaborative care codes for like all the care management and the team site consults and all the other activities. And what we have found, there's also additional copays associated with that. So there's copays if you bill CPT codes, and there's copays if you do collaborative care codes, no matter what. And the other thing that we are finding that we have done as kind of a backup to help with folks who are uninsured is kind of like a backwards way of what Erik was talking about. So we have what we call community care fund, which is basically a lot of money that we can use to help folks who are underinsured or not uninsured. And so if we see someone isn't insured or underinsured, like they have, $10,000 deductible or something, what we'll do is we still bill them, but we immediately during the warm handoff refer them to our community cares program, and they get them signed up so that their bills are then wiped clean.
So the general theme, if I can generalize, is that you create flex on the clinical side to deal with the inflexibility on the billing side, is essentially what you're trying to do. And you do it within the legal constraints of a very, I would say, illegal system, right? But I do encourage people to think that way, because the system is not a moral system. You have to understand that it's a game. It is purely a game. So you learn how to play the game within the rules of the game, and then you focus in on what's important clinically, and you get that done. Hopefully, no matter what, right? So I think that's what I've seen people do. You just create the clinical workarounds to deal with the billing and flexibility. I'd like to ask a couple of quick questions here, because I think these are also important pieces here. It seems like a simple thing, but I've seen places struggle with this. It's just about capturing the minutes. And as some people pointed this out on the thing, can folks just quickly give some creative ways that people have thought about this and kind of found unique solutions? Because everybody has found different solutions. There's not one size fits all, but just the idea of capturing the minutes. What do you guys have for that?
Ours is built into Epic. We have Epic. We have what's called a time tracker. every time they open an encounter that is an activity that they would bill for, in theory, under the collaborative care codes, they enter in the time tracker, and at the end of the month, that's tallied up in their reporting workbench or their registry, if you want to call it, and they just push send, and the bill gets sent.
This is Monica. Same thing as Shanda. We have Epic, and so we've built a flow sheet in that our clinicians can document in, and there's time there. And it's a time tracker. Does the exact same thing.
Yeah, Epic has provided some pretty reasonable solutions for this in the last year or year and a half. There are sites that I've had that are on legacy EHRs that don't have these. Any solutions for folks there other than just like manually counting?
I'll chime in there. You know, we as an organization are EHR agnostic. And although we do work, we just signed a new health system that uses Epic, so we're now using the Epic registry as well. But generally speaking, we're EHR agnostic. We have a registry that's homegrown internally that sits on top of the individual EHR, and it pushes and pulls data back and forth on a nightly basis. And our system has the same capability, so you can basically do a time tracker. So it was a kind of a quick workaround. We also track activities and allocate time towards activities. And we build our assessments to kind of check the box in each category. So I think a combination of either tracking time individually or tracking activities and allocating time to those are good solutions.
And I think particularly if you are on, sorry, go ahead.
No, I was just going to say, I will say clinics that I've worked with that have not had Epic, I have encouraged them, if their IT is like the best thing since sliced bread was invented, if you like sliced bread, to get with their IT to kind of figure this out. I've also had clinics that have utilized the AIMS tracking sheet because it kind of has it all there for you if you're not in a situation where you have IT who could build it in or Epic.
And hey, it's Lori Rainey. Just one more quick point. If you have nurses, if you guys have been doing PCMH or you've had nurses in your clinic who've been doing nurse care management for years, they've had a code, a 20-minute code that's been out for quite a while. So ask your nurses how they do it. You'll see them sitting there with a notepad, 6 minutes, 8 minutes, 12 minutes, jotting down names. You'll see them actually doing that. So they have figured this out because the chronic care management codes came out before these did. The collaborative care codes were simply modeled on the CCM codes that the nurses have been using for your patients with 2 or more chronic physical conditions. So ask around in your clinic. A lot of the EHRs have care management packages. What is it? Something Planet. Cerner's got one. Centricity's got one. They've all got one. And so the nurses have been doing this and counting for a while. So that's where we often find the little gems embedded for keeping track of time. The nurses have been doing it for a while.
Great point, Lori. The other quick question I had for you all was actually going back to Erik's point before about adjudication. So, and this is just sort of crowdsourcing information from you all, but for those of you who have attempted to bill, what sort of positive billing rate have you encountered? And have you noticed anything, any parallel process between the psychotherapy code billing and the collaborative care management code billing as far as the actual adjudication of those claims? Because the other kind of piece that that I think is an unspoken part of the billing conversation is we can figure out how to bill on our end. That doesn't mean we're going to actually get paid in the end. And the actual percent of paid claims, if you look at it within your organization, I've had some scary responses back just for psychotherapy codes or H&B codes. As low as I've seen about 25% in some cases. And so I'm just wondering if folks out there have observed whether these claims are getting paid when you're putting them out there, or is that something your organizations are tracking? If not, my encouragement is please track those. Like you've got to follow the claim all the way through to completion to make the thing work. So any thoughts on that?
Ditto, please track it. That has been one of the most frustrating pieces for me, that in implementation, a lot of times the billing department is kind of left out, which is not good. So what I have been experiencing currently, I have experienced before, is really getting in touch with the billing department who are getting any claim denials and things of that nature so that you could figure out why. Sometimes it's as simple as something that could be changed on the clinical side, a piece that we're missing, but also making sure that they're having conversations about this as they're working on contracts, that I think some people don't always think about, that it's something to bring up and have a discussion about. I also fortunate enough, again, that we're a big enough system that they look at more than just the billing. They're also looking at the quality measures that are coming up for patients. And so it has, right now, everything has been on the small scale, which was my recommendation before kind of opening up the floodgates to the entire system, because there's quite a few practices involved. So far, I've been trying to keep things on the small scale to make sure we work out all these kinks before we open it up big system wide. But there's been a lot of conversations with billing, making sure there are things in the contract as well as IT as we're setting up things. But that's been my experience thus far.
Yeah, Monica, I agree with you. The billing has been our biggest frustration. We've had about probably nearly 50% of our claims that have come back with denials, and we've struggled with finding that person or people in billing that are going to follow it through to the completion of why was that denied. And just glancing at it, there's some clerical stuff like, well, it was put in under the care manager, not as the PCP, and for collaborative care code, it's billed under the PCP. So things like that, they're very frustrating. We're like, oh, if we just got, better workflow with doing the billing, I think we'd get better reimbursement. But yeah, that's a very big frustration. Also in Illinois, we were supposed to have our Illinois Medicaid turn on the collaborative care codes. It was even a law that was supposed to take effect January 1st. And in reality, it's not on the Illinois fee schedule for Medicaid. So we have not seen the ability to bill collaborative care codes for our Medicaid patients, which was really frustrating. We all threw a party last year thinking, yeah, we finally got collaborative care for Medicaid. And when we billed it, they're not paying for it yet. So blame it on COVID. I don't know. Hopefully they'll do it soon. So.
Well, you can blame it on COVID or you can blame it on the state of Illinois. I can say that I lived there for many years.
Totally. It's totally the Illinois government fault.
You need to know someone, you know what I mean? Yeah, it's the state of Blagojevich. What can you say? All right, we've got just a couple of minutes here. This has been a great conversation. Thank you so much to everyone. Just want to double back to make sure. There was some question before about, this was, I think, between Shanda and Lori Rainey and George related to the psychiatric consultant time, et cetera. Did that get wrapped up? Did you guys feel like you had you got the correct consensus on that particular question? Because there seemed to be a little bit of difference of interpretation.
So maybe I can clarify about what I was asking. So we are looking at trying to implement we're not doing the CC codes yet. We're like a half a step away from it, but we're doing CPT codes. And so we were trying to figure out how to make a consistent workflow to document that the consulting psychiatrist is doing that initial kind of touch base about that patient, because you can't drop the bill until that happens. And I was asking, so someone gave me a good idea for workflow. And then also there was a question about who can be the consulting psychiatrist. Am I right?
Yep.
And it doesn't have to be a psychiatrist per se, right? It's like a prescriber.
I think one of the things about that conversation around, does the patient have to have a psychiatric consultation in order to be able to bill for collaborative care? Our CMS is vague and sometimes misleading in their guidance, I think, about this topic. And they have declined to further clarify or try to make it, more clear. unfortunately, up until recently, I mean, they haven't clarified anything yet. The guidance that they have given us at Ames Center over the phone in an informal conversation was that every patient does not have to be reviewed in an individual consultation in order for you to drop a bill that month. The rule is that the psychiatric consultation time has to happen every week, and that both the care manager and the psychiatric consultant would review the entire caseload, looking for patients who aren't improving or have specific problems that need to be addressed, medication questions, diagnosis questions, whatever. And that, yeah.
How do you document that?
You don't. I mean, you really don't document it, other than that you can make a statement, and we encourage people, and there's copies of this in that APA link that I gave you in the chat box. People put a statement on the bill that says this patient was part of the caseload review activity every week and was discussed as needed for an individual consultation. So that statement is there. The only time that gets counted is if an individual patient was actually discussed between the care manager and psychiatric consultant. So it's not realistic to carry it. You need to carry a caseload of 60 to 80 patients in order to be financially viable and to be able to be providing, good quality population-based care. And it's simply not realistic to be able to discuss every single patient, even in a month, even in a full month, because you're talking about, 6 to 8 patients, maybe 6 to 10 patients of the super efficient team at each meeting. And so you're simply not going to be able to do it. And that certainly, the collaborative care model was not designed to just do a 2-minute overview of every single patient every week, or every month. That doesn't make any sense. That sort of runs counter to the idea of efficient use of psychiatric consultation time.
And what I would say is this becomes an issue as patients stabilize. So don't think your patients don't have to have a psychiatric consult, because they do. So early on, when patients come into collaborative care, the way we set up, it's a 1-hour meeting with the psychiatrist. And like Deborah said, or psychiatric consultant, like Deborah said, we can't review 60 to 80 patients. It's too much. We got 1 hour. That's what's in our contract, to review that registry per person per week. So we're going to be prioritizing with the care manager which patients we're going to talk about that week. It's going to mostly be all the new people. We need to put together a treatment plan. That's in the CMS guidelines. The next thing is going to be the people who aren't getting better. Like Deborah said, the model was never meant to count minutes. It was meant to focus the psychiatric expertise on the people who aren't getting better, not on everybody, but who aren't getting better. It's what CMS hasn't helped us with is, well, what about all these people that are getting better? I don't need to talk to the psychiatrist this week about them, but it's left this gray area. So for people that are getting better, what do we do? What's that vague statement we make? And many of us have done it in all sorts of different ways, just tried to touch on them or something, but that's the vague gray area that we're talking about. It's for people that are getting better. Everyone needs to have a consult. All the folks, when they're actively starting treatment, everyone's going to get it, because they wouldn't have entered collaborative care if they weren't. It's towards the tail end. How do I document? And at the end, because people don't stay on the registry forever. 6 to 9 months is the average, and I actually have a lot of sites where it's about 3 months, and they're good to go. Their PHQ-9 or GAP-7 come down, they're doing fine. They come off the registry. You stop billing. Even at the end, the psychiatrist, you're doing a relapse prevention plan. The psychiatrist is writing a note if they're on meds for the PCP, hey, I'd keep them on it for 6 months or take them off in a year. Or even then, you're writing a final note to guide the primary care provider if needed. So it's just that tail end that gets a little iffy.
Yeah, and this is Phillip. I mean, we set up triage to really, talk about those types of things. I mean, using the psychiatrist's time is incredibly valuable, and it's limited. I mean, you're right, we can't talk about 100 people. And so really those who are getting better are our visits with the psychiatrist. We still tried to make sure we were discussing them once a month, but it was something to the extent of we reviewed the case, PHQ-9 scores were stable at a good point or were showing reduction, and that we were going to maintain kind of treatment. So it's fast, and it has to be, because like you guys said, this is not designed to see a large number of people in regards to what a large clinical practice sees. And so you do have to make sure you're really utilizing that time as best as possible.
Guys, I have taken you guys over. I'm a poor time manager. Blame it on my Latino blood. That's what I blame everything on. But thank you so much for this discussion. I'm feeling like we should get together again and recheck in because a lot of you are in development here. So if you all are game, I'll bring us back together in a few months, hopefully not too much down the road, and check back in. And as a little bit of a homework assignment for those of you who are implementing or at various stages, if you could track your bills, if you could go to your billing people and figure out ways to track what's going on with the payment and bring that full circle, I think that kind of information would be really helpful to hear about next time. But thank you all so much to everyone who participated, everyone who contributed to the chat. You're what makes our community such a supportive place for us to figure how to best take care of our patients. And thanks especially to the folks from the AIMS Center who joined in today.
And feel free to come to our financing office hours once a month, the first Wednesday of every month. And I know some of you already are coming. I recognize a lot of names, but that's another great place to get feedback from other folks doing this.
That's right. Great. Thank you. Have a great rest of your day.
All right. Take care.